case is a 34-year-old male with Chagas myocarditis is admitted for recurrent chest pain and is found to be positive for H. pylori. You decide to get an EKG, and it is notable for a QTc of 510 milliseconds. Which treatment regimen should you prescribe for H. pylori gastritis in this patient? Triple therapy, quadruple therapy, quintuple therapy, or did I make up option C? I'll give you 15 seconds to think about it. Try and commit to an answer that will help your learning once we review everything. Okay, the answer here is quadruple therapy. So this is actually based off a patient that I saw with Chagas disease at all of you as an intern. And we had this exact problem. He had recurrent chest pain and everyone was very worried that it was a recurrence of Chagas myocarditis, but it ended up being dyspepsia from H. pylori. Once we treated the H. pylori, his symptoms went away. The QTc was an ongoing issue because he kept going into stable VT or non-sustained stable VT. And so definitely something to consider. So what the heck is H. pylori? This is formerly known as Campylobacter pylori. It's gram-negative, it's helical, and it's bacteria. It penetrates the antrum of the stomach, so that's where it likes to hang out in your stomach, and it can cause gastritis, and it can cause mucosa-associated lymphoid tissue lymphoma, so MALT lymphoma. It also causes marginal cell lymphomas too, but this is just a quick overview for everyone. So what are the treatment options for H. pylori gastritis? This is definitely a simplification of the options. If you're not sure, you should definitely talk to ID. There's a fantastic pharmacology review article that will be at the link it'll be in the very last slide that you can look for. But to review, first line therapy is triple therapy. That includes clarithromycin, a PPI, and amoxicillin or metronidazole. On the other hand, you have quadruple therapy, which is typically second line, and that's bismuth salt, proton pump inhibitor, a tetracycline, and metronidazole. So two specific considerations we're going to review today are penicillin allergy and QTc prolongation. Other things that are discussed in the article, but I didn't want to overwhelm you with for 5 minutes of teaching is if you have prior macrolide exposure, if you're in a geographic area of macrolide resistance, if the patient is pregnant or breastfeeding, there are different considerations. So if you're interested, you should read the article. I found it very, very informative. So here is the triple therapy and quadruple therapy for you to look at. So if you have a penicillin allergy, that means you need to avoid amoxicillin. So just staring at the options on your right-hand side, probably not that one. So what's left? Triple therapy with metronidazole or quadruple therapy? I will say, and this is the case with many patients, make sure to ask about the penicillin allergy, the nature of it. Very often, it is not a true allergy. It happened in the past when they were a child. If it's a time-sensitive thing and you need to give them treatment, triple therapy with metronidazole is fine. Otherwise, you should actually do skin testing to see if they're truly pen allergic. If you have QTc prolongation, we can now review the meds again. You have to avoid clarithromycin. So if you need to avoid clarithromycin, you should not get triple therapy. So what does that leave you with? Bismuth quadruple therapy. There are things like dual therapy. There are times when you can switch out levofloxacin for amoxicillin. Levofloxacin, please remember, does prolong your QTc as well, so it wouldn't be an option here. We're almost done already, so less than 5 minutes. So H. pylori treatment considerations. At the bottom is the name of the article in case you're interested. Remember that H. pylori is primarily in the antrum. Here's a review of triple therapy and quadruple therapy. It's okay if you forget. I looked it up when I made this talk. If you have a penicillin allergy, obviously do not give amoxicillin. So your options are metronidazole triple therapy or quadruple therapy. And if you have QTc prolongation, don't give clarithromycin, but quadruple therapy is sufficient. That's it. We're done. Easy peasy. Questions, comments?
Hey, Dr. Patel, I have a quick question if you have time.
Yeah.
I know that I think from my time at all of you that the resistance to triple therapy is high there. Do we still treat that the same, like in the population at the West LAVA or at Reagan?
It's a different pattern at all of you. I don't know what the pattern is here, but it is different. That I do know for sure.
Okay, so triple therapy would be an option for patients here.
Correct.
Cool.
Okay. So there's the bit.ly link here, and we'll have every week there's going to be the new slide. So this slide is going to be on there. If you have feedback for us, just type in feedback after that. I've gotten a whopping 0 responses so far. But if you actually have anything that you want us to teach about, let us know. It's not going to be just me. It's going to be multiple faculty. That's all. Happy Friday, everyone. Have a nice 3-day weekend. And for those of you working over the weekend, thanks for being here.